Okay? Neutrophils, lymphocytes, monocytes, eosinophils, and basophils. So it's easy if you know the mnemonic. Never let mom eat beans. All right? Make sure you know the mnemonic because you got to remember it. Well, it also puts it in order for you. See that? Neutrophils, 60%, 30, then 8, then 2, then 1. So it actually puts them in order of prevalence. You understand, Kathleen? All right. Let's go through it. Before I start going through it, I want to go through gram-positives, gram-negatives for you. All right. Why? Because I'm about to start using these terms. You have not been hearing me use it that much, but now we're going to focus on gram-positive, gram-negative. And I want you to have a picture in your head every time I say gram-positive, gram-negative. Okay? All right, let's check this out. All right, let's start this way. All bacteria start out with an inner cell wall. Or inner cell membrane, let me say that. Cell wall is separate. So they have that in common. That means I can't tell the difference yet. Then they have peptidoglycan wall. Now that's what satisfies the criteria for a bacteria. If you have a peptidoglycan wall, you are truly a bacteria. Okay? But what is a peptidoglycan wall? I know you guys forgot this. I'm going to throw this in here. You start out with, let me see, NAMNAG. All right, so you start out with NAM, N-acetylmuramic acid, attached to a NAG, N-acetylglucosamine, attached to diala, like that. This is the building block of the cell wall for bacteria. So when you want to put it together, you see you bring another diala right next to it. See that? And then the other ones go after that. So NAG and NAM. You just keep repeating this till you've built the wall. Any questions so far? You understand so far, Kathleen? That's the building block of the cell wall. The diala, when they link together, this is what they call a transpeptidation step. Who's building the wall for you? A 55 carbon phospholipid carrier. That's why they call them P55. Now, why do you want to know this little piece of information? Because vancomycin blocked this guy. And that's why they always say it does something to diala. It actually blocks the phospholipid carrier so you can't bring the diala back together. That means the wall falls apart. So vancomycin is the most effective gram-positive antibiotic out there. Why is that? Because gram-positives have a very thick peptidoglycan wall. See that? Things just got to make sense for you to remember it. "40 layers thickness, minimum." That means it can be 80, 90, who knows? But that's a thick wall. Look at gram-negatives, though. A very thin wall. See? So that means once they mention the thickness, I get a point. Now, they don't just outright tell you, they just describe the culture. The culture shows, bacteria with the thick walls and that kind of thing. Or a thin wall. Oh, thank you very much. Now I know who you're talking about. Now I know it's a gram-positive, gram-negative. Okay? Penicillins, PCN, and cephalosporins block transpeptidation. That way, we'll be talking about those, I think, tomorrow. But again, just a little blurb about how you build a cell wall. All right, so the first difference for gram-positive, gram-negatives is gram-negatives have a thin wall, gram-positives have a very thick wall. Gram-positives have something that the gram-negatives don't have. This is called teichoic acid. Teichoic acid is just an identifier. It's not toxic at all. What else do gram-positives have? Exotoxins. But gram-negatives have it too. But here, gram-positives have no endotoxins. Any questions so far? You understand so far, Mabel?
Yeah, sir. Yeah, I have a challenge.
What's your challenge?
You said that penicillin and cephalosporin that they block. Is it peptido what?
Transpeptidation.
What's that?
That's the diala coming together.
Okay.
Yeah. All right. So here for gram negatives also have an outer membrane. See, that's different from gram positives. Gram positives don't have an outer membrane. So I'm going to label it. Gram negatives have an outer membrane that you'll never see in a gram positive. All right, Nolan? Oh yeah, that's an update. Listeria doesn't have endotoxin. They finally corrected that. For a long time, they always said the only gram positive endotoxin was Listeria. So please update your note on that one. I'm glad you pointed that out. No, it says except endotoxin. The only gram positive endotoxin is Listeria. That's no longer true. They finally proved that Listeria does not have endotoxin. Yeah, so does not have endotoxin. So in other words, no gram positive has endotoxin. That was the only one they weren't sure of for years, but now they've done studies to prove he does not have endotoxin at all. So no gram positive endotoxin. So you got an outer membrane. That means the two spaces, look at this, between these two spots, outer membrane and inner membrane. What the heck is that place going to call? They have a name for it. They call it a periplasmic space. So here to here, periplasmic space. So anytime I see this term, I know you can only be talking about a gram negative. There's no gram positive with a periplasmic space or even an outer membrane. Well, all gram negatives have endotoxin. All gram negatives have endotoxin. And a lot of them have exotoxins. So endotoxin can separate gram negative from gram positive infection, but exotoxin cannot, because anybody can have exotoxin. So how do I know somebody has endotoxin when they show up in the emergency room? You ever heard a doctor go into a room and come out and say, oh, he looks toxic? That's what he's talking about. And that's the same term they'll use in the vignette on the board or Comlex. They'll say the patient appears toxic upon presentation to ER. They're trying to tell you it's a gram negative. The only gram positive that makes you look toxic when you come in is Staph aureus, but we'll talk about those two infections later on. All right, so if they say toxic, they just try to tell you it's a gram negative infection. And therefore, when it comes to antibiotic coverage on them, you better pick an antibiotic that covers gram negatives very well. Thank you very much. That's why they're always, Vanco plus gentamicin, ampicillin plus gentamicin. You got to cover the gram negatives if that person looks toxic because you're worried about the gram negatives. Just based on that word. Yes. No, that's just it's a subjective determination. When I look at somebody in the bed and they're just, you say, oh man, he looks toxic. That means he looks like he's severely infected. Yeah, always pick gram negative when they ask you about that one. All right, so now let's look at this endotoxin that we're always talking about. Endo means anchored into the membrane. That's what they mean by endo. There's three pieces to it though. So let me go through the three pieces for you. Piece number one is called lipid A. There's lipid A sticking out, and then there's lipid A sticking into the membrane like that. Lipid A is responsible for the toxicities of endotoxin. You understand that, Zena? Okay. Lipid A is the same for all gram negatives, no exceptions. They're identical for every gram negative. Lipid A, responsible for toxicities. That means if I ask you who causes DIC, lipid A. Heart failure, lipid A. Stroke, lipid A. Everybody follow me? Any toxicity, just say lipid A. Don't start worrying if you read something else. I'm telling you, pick lipid A because I've never seen the answer be anything else. Okay? Yes. Yeah, the toxicity of any gram-negative infection, pick lipid A. Yep. Lipid A is the same for all gram-negative family members, okay? Now there's a piece that anchors across the membrane. So I'll make that different color. Goes like this. This is called the O antigen. The O antigen is different for each family. That means all the E. coli's have the same one. All the Klebsiellas have the same one. All the Serratias have the same one, and so forth. But it's different for each family. O antigen. The O antigen is an oligosaccharide. That means a short sequence of sugars. Who's my one sugar donor when you want to add one sugar to anything, Kathleen? Huh? No, Sam is the methyl donor. I want to donate one sugar. Ashni. Is what? Yeah, UDP. Remember, UDP donates one sugar for anything, everywhere, anytime they ever ask you. Okay, Dolocol is when you want to add several at a time. All right, so O antigen is the same for each family. Okay, but different. Yes. Is this yeah, for some certain bugs. If they're about anti-ASO, let me see. ASO, anti-septicemycin. Oh, I don't think it's this way because ASO is for strep. Strep doesn't have endotoxin. So there's another antigen that he has that they call O antigen. All right, so this is O antigen, different for each family. All right, and then finally, there's a portion that anchors into the inner membrane. So I'll make that a different color right here. That's called the core antigen. Core antigen is different for each gram-negative family member. That means, Zena, if I ask you which one of those three pieces is the most variable, you say which one? The core antigen. Why is that? That's what I'm asking you. How do you know it's the most variable? What did I just say? No, I didn't say it was most variable. I said it in a different way. Again, I said it's different for every gram-negative family member. That's variability. You understand? I'll just make sure you heard it. Okay. So that means, Ramunda, which one of these three pieces is going to cause the most inflammation? The O, the core, or the lipid A? Lipid A, close, but not the best answer. Ashley, which one are you picking? Which one's going to cause the most inflammation? Which one? Core. Why the core? Nolan, which one causes the most inflammation? Okay. The whole thing is called LPS. The man, Cynthia, you think it's the core? Why? Because we just said it's the most variable. You guys forgot variability determines immunogenicity. All I do is change the question with one word. That's what the test writer does, folks. And it's the same question again. Okay, that's why, again, read the question carefully, and then you'll see the answer the same thing. That means, although lipid A, listen carefully, although lipid A is responsible for the toxicities of gram-negative, core antigen causes the most inflammation and therefore the most destruction. Everybody understand that? Listen carefully on them. That means if I kill this gram-negative, does everybody understand a whole lot of lipid A is going to be released? But even worse than that, a whole lot of core antigen is going to be released. Everybody follow that? That means this is going to cause severe inflammation. Anna, what is the first visible sign of inflammation? I can't remember. Swelling. What cells show up first, sir? Neutrophils show up at what hour? 4.5, predominantly by 24 and peak at what hour? What day, rather? Day 3, what cells show up at day 4? T cells and macrophages show up at day 4 and peak at what day? Day 7. Who shows up at day 7? Fibroblasts show up at day 7, peak at what day? 1 month, finish scarring by 6 months. So that means when you get all this swelling, and all this scarring going on in your body, Karina, what organ you worried about the most? Huh? The brain. Notice the answer is still the same. So that means I don't want your brain to swell so much. Why? Because you're going to herniate and die. Anytime intracranial pressure goes up, Karina, what hormone gets released by your brain? No, not all of them. I said, what hormone? That means only one is the answer. Maria will help you on this one. Not cortisol. Sabu will help us. Not norepinephrine. Akshay, ADH. That's why SIADH is common in all CNS infections, meningitis, encephalitis, whatever they want to call it. Okay? SIADH is common. For that reason, they say limit fluids to 75% maintenance on the first day, because you don't know who's going to have SIADH. And if you give them too much fluid, guess what? The brain will swell up too much, they'll herniate and die. So we always limit the fluid intake for any child with meningitis to 75% maintenance for that first 24 hours to make sure he doesn't have SIADH, because the swelling just started. That's when SIADH is most common, that first 24 hours. If they're fine after that, take the fluid rate back up to normal. Solange. Yeah, keeping the CPP. Remember CPP, MAP minus ICP equals CPP. So if ICP goes up because your brain is swelling, it's got to raise the MAP. So it says, let's hold on to water to help you pump more blood up here. Yeah. So it's doing it for a reason, to keep you alive. Okay. Any questions on that? All right. Then it should also help you understand, Reed, why when you treat a gram-negative with an antibiotic on them, the patient is going to get worse before they get better, because all this lipid A is going to be released. All that core is going to be released. Everybody see that? That happens anytime you're treating a gram-negative, folks. Your patient gets worse before they get better. So that means if I put somebody in ICU for, let's say, E. coli or some gram-negative, I start ceftriaxone, whatever I want to start, right? I'm telling you, 2 hours later, the nurse will call me. Hey, you know that lady admitted? Oh, she got DIC. That means I got the right antibiotic. That means I kill a whole bunch of bugs. Imagine if you, the doctor, don't understand, you're actually winning the war. See that? The doctor will overreact and then do something that kills the patient. So it's normal to get worse before you get better for a gram-negative infection. That's what I want you guys to see, so that you don't accidentally pick the wrong answer. When they ask you, what would you do about it? You just treat symptomatically, you know? You give them cryoprecipitate or FFP, whatever you got to do, but you don't have to do anything extra. It means the antibiotic, hello? Oh, it means the antibiotic is working. This thing does go out every now and then, because I can hear it. All right, so that's what you want to understand. Gram-negatives always make you worse before they make you better. And then outside of this, you can have, remember, a capsule. And we got 6 gram-negatives with capsules. Okay, Ida, you're smiling, so that means you got to give me all 6 now. Go ahead. Some killers have pretty nice capsules. Run them off. Salmonella. Klebsiella. H. influenza B. Make sure you have the B after that. P. Okay, she's going to come back. Citrobacter is a C. What at the end? Strep pneumonia is gram-positive. I don't want gram-positive. I want gram-negative. You're missing 2 letters. P and an N. Bailey, help her out. Oh, you did? Well, then why'd you say it again when I'm asking you? Okay, I said, what's the N stand for? You didn't say anything. Yes, Neisseria. What's the P then? Okay, Bailey can help her out. No, not Proteus. It's Pseudomonas. All right, now watch my arrow, folks. Oh, let me get my arrow back. Watch my arrow. That means when you are treating a gram-negative, watch this. If it's encapsulated, that means you got to break through this capsule, just to break through this outer membrane, just to break through this peptidoglycan wall before you get to the bacteria. Do you see that? Why do you think they want you to know they're gram negatives with capsules? Those ones will kill you real fast. That means before your antibiotic can even kill this thing, he's already killed your patient, which is why we start antibiotics as quickly as we can. That's why whenever you suspect one of the encapsulated bugs, they tell you to move real fast. Don't waste any time. That's why I want to make sure you guys understand it, so you understand somebody's life depends on how fast you move. Okay? Question? No. Strep pneumonia is gram positive. She just said that. Yeah. So it's the only gram positive with a capsule. Yeah. The only gram positive with a capsule. There's 6 gram negative with a capsule, but there's a fungus with a capsule too. So that's why they want you to know it's a short list on both sides. Now, the life cycle of a bacteria. Let's see. I need somebody to help me on this one. Angelique, you help me on this one. The life cycle of a bacterium goes like this. There's a period of time where it's getting used to the environment. That's called lag time or lag phase. So the phase of where the bacteria is getting used to the environment is called lag phase. The amount of time it takes for that to be done is called lag time. They'll tell you how much time that is. Then it goes to a time of division. So we call that log phase. And then there's a log time. That means how much time does it take to double the amount of bacteria? For 2 to go to 4, 4 to go to 8, and so forth. So we got lag time first, log time second, and then we have a plateau phase. Plateau phase is when there's as many bacteria replicating as are dying. So if 10 divide and then 10 die, guess what? You got the same number. That's what we call plateau phase. It looks like the phase 2 of the action potential, which is controlled by what electrolyte, Jess? It looks like the plateau phase or phase 2 of the action potential controlled by what electrolyte? Not potassium. Potassium's downward slope. It's calcium. All right. So Mabel, after the plateau phase, there's another phase called the decline phase. During the decline phase, Mabel, you got more bacteria dying than are replicating. You understand that, Mabel?
Yes, sir.
All right, if you understand it, Mabel, here's the real question. During which of these phases does the bacteria release the most endotoxin?
I think it should be it should be as a flatus phase, right?
I don't know. Just tell me an answer. Which answer are you picking?
I think it should be at decline. Let's go to decline when they're almost dying.
Okay, why the decline phase?
Because they're dying, they're at rest. Kind of repolarization, something like that.
I don't know what any of that means, Mabel. Tell me why you think bacteria release more endotoxin during decline phase.
So because they are weak. At this point, they are weak. They have finished everything. They have finished all the activity. They are weak now, trying to retire and all that, you know?
No, Mabel, that's not it. Okay, let me ask Paul.
Is it the same reason why when you give the antibiotics, your patient gets worse because they're releasing all the endotoxins from the inside?
Yeah, it's the same thing I just explained, Mabel, is that when you're treating gram negatives, you start killing it. That means all these walls start coming down. Well, the endotoxin is anchored into that wall, and that means it's going to be released. So decline phase is where most bacteria release the most endotoxin, except one bacteria. Because she's not so nice. Wait a minute, Mabel. Because she's not so nice, Neisseria. is the only bacteria that releases a ton of endotoxin during the log phase. Nobody else can do that. Because she has the biggest capsule. I mean, endotoxin just oozing out of the membrane, even though the membrane is still intact. So if they ask you about a bacteria releasing endotoxin during the log phase, they gave you the point. There are no other bacteria that can do that. All the rest of them release endotoxin during the decline. That means as they're dying and the wall is falling apart, everything in the wall must be released. All right, Mabel, do you have a question?
Okay, so you said it's decline because they are dying and everything is falling apart, right?
So the walls are falling apart, releasing all the endotoxins anchored into the wall. You understand?
Yes, everything, yeah.
Okay. Anna. Is that why meningococcus causes adrenal insufficiency? That's correct. Because it causes so much inflammation in the adrenal gland that it finally shuts down. They bleed right into the adrenal gland. That's called Waterhouse-Fredrickson syndrome. We'll talk about it when I get to Neisseria. But again, I'm just setting up everything. So when I get to the bugs, it goes real fast. I'm just going to tell you what's different about each bug and keep moving. All right. But that's why I got to make sure you guys understand this, because this is where the knowledge comes from. Any questions on that? All right, cool. Here's another way, Karis, to analyze this. If I were to give you a bactericidal antibiotic, which phase am I putting that bacteria into? Apoptosis. You see apoptosis in this picture? We're talking about life? How do we switch to life when I'm on bacteria the whole time? Oh, yeah, I'm going to say, you definitely were not here a second ago. Talking about we having a discussion about life. When did that start? That means she was off somewhere, man. You guys kill me, man. Okay, so anyway, the point is, I forgot the point. All right, here it is. The point is, if they ask you about a bactericidal antibiotic, penicillin, cephalosporin, all cell wall inhibitors, right? You can't live without your cell wall. You die. So that's why cell wall inhibitors put you into the decline phase. And that's what they'll ask. An antibiotic like penicillin will put the bacteria into what phase? Then you got to remember the phases because it's going to kill. But Anna, what if I give you a bacteriostatic antibiotic like the macrolides? You don't die when I block protein synthesis because you already have some proteins before I give you the antibiotic. And that way that bacteria can still live for a while. If I give you a bacteriostatic antibiotic, I'm putting that bacteria into what phase? No. Lag phase is before anything even happens. Yeah, plateau, because the bug already started replicating, so you can't call it lag phase anymore. Yeah, so bacteriostatic antibiotic like macrolides put the bacteria into plateau phase, which means your neutrophils and your macrophages can then eat them. That's how bacteriostatic antibiotics work. Remember, drug action is all over your exam, folks. That's why understanding these basics will explain so much. Yes, sir. Exactly. Bacteriostatic is indirectly killing. It's just holding it still so that the immune system can kill it the rest of the way. And then here's the one they like to ask the most, Karina. Here's yours. If you give somebody a prophylactic antibiotic, that's because you're trying to lock the bacteria into what phase? The lag phase. So when we use prophylactic antibiotics before surgery, see that? That's the one they always like to ask. What you're doing is locking those bugs into the lag so they cannot start replicating while I'm cutting my patient. And that's because Karina knows while I'm cutting my patient, he becomes immunocompromised. And if he becomes immunocompromised, those bugs can start growing. That's why you hit them with a prophylactic antibiotic so they can not start growing. If they did start growing, though, Karina, what organs would I find the most bacteria growing in? which is why they get infections in these areas after surgery. Lillian wants to help you out. You know? No, not blood. Maria. No, not skin either. Let's go over to acid. Where do you get most infections after surgery? He didn't make the connection. Wait. Thank you very much. A little delayed there, but he got there. Gee, where do you get that from? What I tell you? You guys always think it's some new answer. This is how the test writers get you guys. Until you realize everything keeps going on in a circle. Pulmonary UTIs. Look at the most common infections after surgery. Pulmonary UTIs. I didn't have to go read any literature to figure it out. All I got to do is make the connection. I said, oh my God, that's why we see these effects. All these things are making sense to me. But that's why if you don't learn the basics, you can't see it when they apply it to complex. Because that's when you think it's a new answer, and now they got you. Because you're going to pick some new bug, and that's it. They got you. You missed it. Yes, sir. That's correct. For gram negative, well, it depends on how bad the gram negative. If it's encapsulated ones, we want to kill that thing as quickly as you can. Yeah, even though the patient will get worse before they get better, I'd rather kill this thing. Yeah, but if it's not that bad, yeah, we just want to hold it still, let the mucus neutrophils eat this guy up. Yeah. See, this is how you make a decision about what kind of antibiotic do you really want to use. Most physicians are not taught that, though. They just know that the book said ampicillin gentamicin. That's all they remember. Yeah, there's no discussion about why did they pick this combination. Okay. Yeah, but anyway, this way you guys know. All right. Let's see. Okay, we've gone through this. Let me just start the next topic before we break for lunch here. Gram stain. Gram stain is usually worth 1 point on exams. That's why I threw it in. You just got to know the steps. So there'll be a question about one of the steps. That's it. It's an easy point. Step 1, add crystal violet. That crystal violet binds to exposed peptidoglycan. Whose peptidoglycan is exposed, Gustavo? Gram positive, gram negatives. All right, Mabel, whose peptidoglycan wall is exposed? Gram positive, gram negatives.
Peptidoglycan is gram positive, sir.
Yeah, remember, gram positives don't have an outer membrane. You understand, Gustavo? Yeah. So the crystal violet, which is purple, stains the gram positive. That's why gram positive stain purple or blue, depending on what book you look at. Okay. Step 2, add iodine to seal it into the wall. That means now the gram positive are permanently stained purple or blue. Then step 3, wash off the excess with alcohol. That means the gram negatives are nice and clear again. Gram positives already have their blue color. And then we add saffron, which colors the outer membranes, which is pink. That's why gram negatives look pink and gram positives look blue or purple. Any questions on a gram stain? Again, they always give you the gram stain, folks. It's always in the vignette. That's why you want to know how it's done so that you gain information from it. All right. Acid fast stain is the opposite. An acid fast stain, Jess, also called Ziehl-Neelsen stain, the pathogen stains pink, like tuberculosis. That means the pathogen, TB, will stain pink. All the other cells will stain blue. So in an acid fast stain, you focus on the pink color. The blue, you don't know what cells they are, but they're other cells, because all of them stain blue. Only 3 bugs you want to know. Completely acid fast, Mycobacterium family. That's it. There are no others. But partially acid fast, nocardia is a gram positive, and then cryptosporidium is a protozoa. Nocardia likes to attack what group of people, Angeline? Nocardia likes to attack what group of people? And so let's see if Justin remembers. Acid remembers? Abi? Not IUDs. Let me ask Karis. Which immune compromised? Diabetics specifically. Say diabetics on the test. Yeah, not all of them. Yeah, it's only diabetics. They love diabetics. Remember, I told you lung infection or sinus infections, nocardia if it's a diabetic. And then cryptosporidium causes watery diarrhea. Rice water diarrhea. What group of people, Gloria? HIV patients. Watery diarrhea, is that secretory or osmotic, Gloria? Secretory, which means osmolarity is high or normal, or high or low rather. It's low because you're diluting the stool, right? Is it going to continue or stop if you make them MPO? It's going to continue because it has nothing to do with what you've eaten. Remember, osmotic diarrhea has to do with the sugars that you've eaten. All right, very good. All right, let me just do neutrophils and we take our lunch break here. Neutrophils, the most abundant granulocytes in everybody. They make up 60% of your white cell count. These are first line defense, right, Rachel? Right? So they show up at 4.5 hours, predominantly at 24, peak at day 3. 10% are circulating, 90% marginating. Just to remind you, that's all. They contain myeloperoxidase and NADPH oxidase. So here's how NADPH oxidase helps you kill bugs. All right, the first wave of killing, they take oxygen and water and make hydrogen peroxide, which is just another acid. But how is it that acid hurts you? I heard acids can hurt you one of 4 ways. Rachel, hit me 4 times. The 4 ways acidosis can hurt you. All right, she forgot. Read. Kussmaul breathing. Denatures your proteins. GABA. Last one, Amy. Last one, Sandra. Last one, Montessori. Huh? No, it produces free radicals. I'm just saying, how does acidosis hurt you? 4 ways. She gave me 3. I need 1 more. Gustavo. Hyperkalemia. So that's why when neutrophils show up, listen carefully. GABA kicks in. Why do you think that child is moving so slowly? How come you're feeling sleepy when you're sick? I told you constants don't change. They have a new name to them. Okay? That's the reason why you slow down when you're sick. You're swimming in GABA all of a sudden. It's denaturing your body, denaturing your muscles. And that's why you see you're just laying on the couch. They don't want to move. That's because your body is denaturing. Okay? Then hyperkalemia is how so many people die early in their sepsis. See? And then Kussmaul breathing, you see, breathing hard. You know, the mom can tell, hey, Charlie, we better go to the emergency room. She can tell. Charlie's slowed way down and now he's breathing hard. Okay, to the emergency room. Okay? Anyway, that's the first wave of killing. Hydrogen peroxide. And then to make sure hydrogen peroxide doesn't get out of hand, your body has catalase. And so we have specialized lysosomes, which have a lot of catalase, so they call them peroxisomes, as in hydrogen peroxide. So these are specialized lysosomes with a lot of catalase to negate the hydrogen peroxide. Otherwise, it would eventually kill you, the patient. So folks, what I'm trying to make sure you understand is that it's your body's response to an infection that kills you, more than the bug. It's your body's response, which is why we don't want people to get too many of any pathogenic bacteria, because the response will kill the patient. Okay? And then if that does not work, then we have oxygen with the H2O2, and all of a sudden you produce free radicals. And if you remember, free radicals don't have any friends. Ida, how do free radicals hurt you? Pierce the cell membrane, pierce the nuclear membrane, bust up the DNA into pieces. The cell only has 2 choices left. What are they? Die or mutate. That's it. And then we have myeloperoxidase that'll help you turn some of these into HOCl, which is a weaker free radical. That's the same thing as chlorine bleach. Ring a bell? Why do you put bleach in the wash when you're washing your whites? Now you know. Any questions on this? Otherwise, we'll pick this up after lunch. All right, back at 120.
So I have 2 questions, please.
All right, go ahead, Mabel.
Please, sir, you said that peroxisome is a specialized what?